But what we all know is that these vascular features observed on imaging are difficult to quantify in vivo, and that really represents just a small fraction of just like a small fraction of the overall heterogeneous pathological change in the brain. And it's also widely recognized that small vessel disease is undersampled and underrecognized in these autopsy studies. And all of these neuropath studies are also limited in sample size and prone to severe selection bias towards healthier subjects. Um, but overall, I mean, clinically, there's still no consensus on defining vascular contributions to dementia. So what this really means is we still have no clue how much dementia in the population can actually be attributed to vascular causes. And this has key clinical and public health implications. Because of the high co-occurrence of cerebrovascular and AD neuropathology, there could be enormous benefit from interventions on modifiable risk factors at the population level. And so there's really two primary reasons for this. So first, obviously, preventing or treating vascular risk factors could reduce dementia risk that's primarily attributable to vascular lesions. So this figure here comes from the most recent NIA AA recommendations for defining Alzheimer's disease as this biologic construct, so the ATN framework. Overall, it shows the time course of the different pathologies captured by biomarkers, which are believed to give rise to clinical dementia. And so I annotated this figure here to kind of place things in context, to include vascular lesions, which is denoted by the red line. So if we posit that the critical period for vascular disease impacting dementia risk is in midlife, it could be that the cerebrovascular damage starts to accumulate before the pathological hallmarks of AD start to accumulate. But vascular risk factor interventions could also potentially reduce some of this risk that's attributable to Alzheimer's processes. So there's some evidence linking cumulative midlife vascular risk factor burden with elevated amyloid on PET in the ERIC study. And recent work led by my mentor at UNC also demonstrated that midlife hypertension and diabetes specifically was associated with a faster rate of change of the plasma biomarker p-tau181, which was also done in my ERIC study. But how this translates into the overall clinical picture, though, so in this figure, it postulates that the effects of comorbid pathology, such as vascular lesions, could be pushing forward clinical symptom onset and presentation of Alzheimer's dementia. But again, the evidence is not so much there yet for this. And so to really estimate the overall preventive potential of reducing vascular risk factors on dementia, we really need a more nuanced measure here. So all of these epidemiologic studies obviously can tell us that hypertension and diabetes and smoking all increase risk of dementia, which is really nothing new. And these risk factors are all usually associated with modest relative risks and pretty low, like very, very low positive predictive values. So to make inferences about dementia prevention in the population, we need to account for how common these exposures are in the population. And this is really, really, really critical for vascular risk factors, which are known to have a high prevalence in the US population. And so one public health measure that I'm very familiar with now, and that's useful for making inferences about primary prevention, is the population attributable fraction, or the PAF. So what PAFs tell us is that in a population consisting of both exposed and unexposed individuals, what the maximum fraction of average population level dementia risk is attributable to a given risk factor. Or in other words, if we completely intervened on the exposure in the population, what reduction in dementia risk could we optimistically hope to achieve? And so that's the translational value here. And so this is shown in the diagram that I made on the right, where there's a hypothetical intervention that shifts the curve of blood pressure levels down so that which could reduce average dementia risk, not at the individual level, but at the population level. And PAFs are also useful, I think, and this is a really critical point, they're useful for making careful etiologic inferences when clinical trials aren't feasible. So for example, it's not feasible or realistic in will never be done to conduct a study to assess the impact of tight blood pressure control beginning in midlife on reducing dementia risk, given the decades of follow-up that would be needed, and obviously because of the early stopping for known cardiovascular benefits. So estimating these PAFs from vascular risk factors can really help bridge this huge gap between clinical and neuropathologic evidence to estimate the fraction of dementia burden that's attributable to vascular causes. And so previous research has estimated PAFs of dementia from a wide array of known modifiable risk factors for dementia. This figure here is courtesy of last year's Dementia Lancet Commission on Dementia Prevention and might be one of the most widely cited dementia papers to date. So in this landmark series of studies, the Lancet estimated that around 2% of dementia globally can be attributed to hypertension, around 2% for smoking, and 2% for diabetes. But we believe this PAF estimate of around 6% of dementia being attributable to vascular causes is probably unrealistically conservative. And so in service of this, we previously reported on the fraction of dementia risk independently attributable just to hypertension in midlife and late life in the ERIC study. Because hypertension prevalence rises with age, for this study, we hypothesized that the fraction of dementia risk attributable to hypertension only would increase from midlife through early late life. And I'll reserve slides for a lot of these methods for later in the talk because much of this is shared for the next study. But here I'll just display some of the primary results of this preliminary study. So in this figure on the y-axis is the adjusted population attributable fraction expressed as a percentage, and on the x-axis is blood pressure category. The individual dots indicate blood pressure measured at age 45 to 54 years, so that's the black dot. Orange indicates blood pressure measured at 55 to 64 years, and the blue dot indicates blood pressure measured at 65 to 74 years. So with dementia restricted to onset by age 80 years, in this study, we found that between 15 to 20% of dementia risk by 80 years was attributable to non-normal blood pressures measured up through age 74. Or in other words, 20% of population-level dementia risk could potentially be mitigated with blood pressure interventions from early midlife through early late life. And initially, this highlighted a really significant preventive potential from this high prevalence risk factor. Given up to 20% of dementia risk could potentially be mitigated from addressing non-normal blood pressure values, even through early late life. So medication is relatively inexpensive. Lifestyle modification is feasible, but there's also policy and legislation that can impact both of those. However, we found that hypertension in this study measured up through age 74 contributed little to dementia onset by 90 years of age. And when hypertension was measured in those aged 75 and older, which is indicated by the red dot here on this figure, hypertension made no contribution whatsoever and was actually associated with a negative PAF. So this study demonstrated that not only is age of risk factor measurement important to account for our understanding of the vascular contribution to dementia across the life course, but so is also explicitly defining the age of dementia onset. And we think that finding specifically is because dementias occurring after age 80 have a more heterogeneous neurohistopathology. The contribution of any one etiology is probably diminished when considered alongside a plethora of others. So that includes Alzheimer's lesions, that includes TDP-43, it includes Lewy bodies, et cetera. And so this aspect of considering different ages of dementia onset was novel to this PAF research field, and we carried this forward in our other work. But that was hypertension alone. Vascular risk factors frequently present together, and we've known this for a long time as well. So this figure comes from our recently published article that shows clustering patterns for hypertension, diabetes, and smoking, specifically in the ERIC study. So the dark blue bar there indicates having no vascular risk factors. That bright red bar indicates hypertension only. Green indicates diabetes only, and that light blue indicates smoking only, and so on and so on. But what I really wanted to emphasize here in this figure was that first, they cluster together even beginning in midlife. And second is that diabetes specifically is more likely than not to co-occur with hypertension. And you can see this by comparing the purple bar here with the green bar here. So up to 9% have these two risk factors in midlife when you look at the purple bar. And this actually jumps all the way up to 18% in early late life. So 18% of individuals aged 65 to 74 years have hypertension and diabetes only. So this really still has a lingering question of, given what we know about vascular risk factors concentrating together, how much dementia in the population is attributable to having more than one vascular risk factor? Or in other words, really getting at the main question, how much dementia can be collectively attributable to vascular causes? And so this was our recent study published in JAMA Neurology, where we aimed to quantify the summary contribution of modifiable vascular risk factors, so hypertension, diabetes, and smoking, in midlife and early late life to dementia incidence. For this study as well, especially based on our prior work for hypertension, we hypothesized that the contribution of vascular disease to dementia would rise from midlife through early late life. And so as with that preliminary hypertension study, we used data from the ERIC neurocognitive study. So it's a well-known study, but for those that aren't too familiar with it, ERIC's this ongoing community-based cohort study that recruited around 16,000 participants aged 45 to 64 at baseline from Minneapolis, Minnesota, Washington County, Maryland, Jackson, Mississippi, and Forsyth County, North Carolina, in 1987 through 89. And so in part because of how well phenotyped this cohort is in relation to their vascular risk over the course of several decades, ERIC NCS was then specifically initiated in 2011 to investigate vascular contributions to cognitive decline and dementia. That's a really important point here to note. And so in terms of the study design and population again, so we used vascular risk factor data collected at ERIC visits 1, 4, and 5. So visits 1 and 4 roughly correspond to midlife risk factor measurement, and visits 4 and 5 roughly correspond to late life risk factor measurement, depending on how old the participant was at enrollment. And as I'll get into in a second in a couple slides, dementia follow-up here at the bottom is continuous. So this figure here displays the inclusion and exclusion criteria. So we excluded those that did not identify as white or Black race due to very small sample sizes that limit representation. So around like 20 individuals. We excluded those with missing risk factor or covariate data, and we obviously also excluded those with dementia at baseline. So overall, our sample sizes to estimate PAFs for vascular factors at age 45 to 54 was around 7,700. Then there were around 12,300 participants for analyses at age 55 to 64. And the sample size for vascular factors at age 65 to 74 was around 6,800 individuals. This is also a very important slide. So the primary outcome for all of the, for both of these studies was incident all-cause dementia. So dementia adjudication in ERIC is among the most comprehensive in all cohort studies to date. So the standardized adjudication procedure is blinded to vascular risk factor status and uses neuropsychological test data collected from visit 5 onward, individual and informant reported data collected outside of these ERIC clinic visits, and claims data from hospitalizations and death certificates from community surveillance. I don't include this in the figure here, but as well, there's beginning of visit 2, there's also a smaller battery of cognitive tests that were administered to all participants, which facilitates the measurement of cognitive decline over time for determining a dementia diagnosis as well. So obviously, our primary exposures were hypertension, diabetes, and smoking. We defined hypertension using the current ACC-AHA criteria. So that's a systolic of at least 130, a diastolic of at least 80, or use of medication for high blood pressure. We define diabetes as a fasting glucose of at least 126, a non-fasting of at least 200, self-reported physician's diagnosis of diabetes, or use of any diabetes medication. And then for smoking status, that was defined by self-report. So first for this paper, we first assessed interaction between each of those different combinations of vascular risk factors and incident dementia by age 80 years using a joint effects analysis. So this means, for example, that the exposure variable is categorized as having neither hypertension only, diabetes only, and then both. And so we estimated hazard ratios with Cox regression models adjusted for all of these demographic and clinical covariates right here. And we used those hazard ratios from the joint effects variables to investigate both additive interaction and multiplicative interaction. And that's denoted here down at the bottom. So there was not any evidence for interaction between diabetes and smoking or hypertension and smoking. However, what was new in this analysis was that midlife hypertension and diabetes, which are typically considered the most important vascular risk factors for dementia, exhibited positive interaction and synergy to increase dementia risk by 80 years. And so that's denoted here by the red stars on the right side of the forest plot. So this means that having both hypertension and diabetes elevates dementia risk above and beyond the expected multiplicative contribution based on having either one of those vascular risk factors alone. And then next, so after we assessed interaction, we then estimated what's called a summary population attributable fraction for dementia by age 80 years. So for this analysis, the primary exposure is defined as having at least one vascular risk factor versus none. So the comparison group for this analysis is a non-smoker without hypertension or diabetes. And so this part was a really unique aspect of our analysis and was new to the dementia research literature because this accounts for all patterns of risk factor co-occurrence and all potential scenarios of interaction, whether or not they interact positively, inversely, or not at all. And so it accounts for this because the exposed group consists of those who, like, for example, have both hypertension and diabetes. It consists of those with hypertension only. It consists of those with diabetes only, and so on. And so to estimate a PAF for this analysis, we used a model-based approach to estimate these longitudinal PAFs through the end of follow-up and corresponding 95% confidence intervals. And so what I'll present too, so we calculated it overall in each of those age groups that I specified earlier, and also by ApoE genotype and also by race. So this table here displays the cohort characteristics by age of vascular risk factor measurement and by vascular risk factor status. So just very briefly, there was a larger share of self-identified Black individuals and those with lower education with at least one vascular risk factor present relative to having none. And this was irrespective of age of risk factor measurement. So really digging into the meat of this. So again, for this figure here, the y-axis is the adjusted PAF at the end of time t expressed as a percentage. There on the x-axis are each of the vascular risk factors. And then the individual bars are colored by age of risk factor measurement. So again, blue bars indicate vascular risk factors measured at 45 to 54 years. Orange indicates 55 to 64 years, and then the blue bars indicate vascular risk measured at 65 to 74 years. So overall, the PAF of dementia by age 80 years from at least one vascular risk factor measured in early midlife was 21.8%. And this PAF increased up to 44% when vascular disease was measured in early late life at age 65 to 74 years. And these results here were consistent after several sensitivity analyses, for example, using alternative thresholds for hypertension. And then just to benchmark these estimates, we calculated PAFs of dementia from at least one apoallele, and those PAFs ranged from 14 to 18%. And then we can also look at the patterns for these individual risk factors too. So the prevalence of hypertension and diabetes increases with age. So as you can see, the PAFs here rose with age of risk factor measurement. And smoking decreases with age. And so this is also reflected in the declining PAF here. In early midlife, so at age 45 to 54 years, looking again at these black bars, smoking was associated with the largest PAF, so around 10%. However, beyond age 55 years, hypertension was consistently the largest contributor to dementia risk. So at age 55 to 64 years, the PAF was around 11%. And then when it was measured at age 65 to 74 years, it was around 20%, which is consistent with our preliminary work. But really, to interpret these estimates and place it in the context, what it means is that if hypertension, diabetes, and smoking were all completely eliminated at age 45 to 54 years, as much as 22% of population level dementia risk by age 80 years could potentially be averted. And so moving on, this figure here shows the population attributable fraction of dementia from at least one vascular risk factor stratified by ApoE genotype. The black bars indicate those with no apoalleles. The orange bars indicate those with at least one. So beginning at age 55 to 64 years, PAFs indicated a larger vascular contribution to dementia in those with no apoalleles relative to those with at least one. So for example, PAFs were 33% versus 18% respectively. And then when vascular risk is measured in early late life, the PAF was 61% versus 22% respectively. So essentially what we interpret this as is that there's a larger vascular component contributing to clinical dementia expression on the additive scale and those at lower genetic risk for Alzheimer's disease. And then last, so this figure here displays PAFs of dementia from at least one vascular risk factor stratified by race. So the black bars here indicate white race and orange bars indicate black race. So PAFs indicated that there was a consistently larger vascular contribution to dementia in self-identified black individuals compared to white individuals. So for example, in midlife, the PAF was around 42% for individuals racialized as black, compared to around 22% for white individuals. And so one of the potential explanations for this was that there was very much a higher prevalence of all of these vascular risk factors in black participants in ERIC compared to those that are white. And so as with our previous study on hypertension alone, vascular risk factors overall contributed little to dementias occurring after age 80 years. So on the left side here, we have the PAFs from at least one vascular risk factor. And those PAFs ranged from just 2% to 8%. And not shown here, but when these vascular risk factors were measured after age 75 years, both relative risks for dementia and PAFs for dementia occurring after age 80 were all negative. So that kind of again reflects how diverse neuropathology after age 80 years reduces the contribution of any one of these individual independent mechanisms. And it also raises the question to me of whether or not there's unaccounted for heterogeneity in later life that might be influencing these vascular risk factor associations in late life. I'll just highlight some important limitations to this. So first, our outcome was all-cause dementia, and we couldn't distinguish between any etiologic subtypes. We would expect, though, to see stronger associations with vascular dementia compared to AD, for example. And that was somewhat borne out in our analysis stratified by APOE genotype, which showed stronger associations in those at lower genetic risk for Alzheimer's. However, it's still clinically difficult to make that distinction because clinical presentations are heterogeneous. And again, most dementias are mixed. Second, our subgroup analyses are likely underpowered and should be interpreted with caution. Third, so while we used up-to-date criteria to define our exposures, there still could be residual misclassification. In this analysis, we're not accounting for any potential time varying effects of exposures or covariates, or even accounting for duration or even load of hypertension over time. And we also aren't accounting for hypertension or diabetes treatment, which is important to note. Though our definitions for each of these included whether or not the individual was on treatment. So to me, what that means is that there would these relative risk estimates that are incorporated into our PAFs are probably conservative, since those that are in the exposed group would have lower values attributable to their treatment and therefore lower dementia risk. Fourth, it's also important with estimating PAFs. It's important to know that the prevalence impacts the PAF estimate and the magnitude of PAF the most. However, the prevalence estimates from earlier ERIC visits might not necessarily apply to modern day. And it's also known that diabetes prevalence in ERIC is higher than in the general US population, and so is hypertension. And again, that is a major limitation because prevalence exerts the largest impact on the PAF. And last, estimates are needed for other race and ethnicity populations that aren't captured in the ERIC study. PAFs need to be calculated across populations and contexts because vascular risk factor profiles vary across contexts. And to really maximize the translational value of these estimates, they should ideally be calculated at the intended level of intervention for specific target populations. However, we still think that these PAFs we estimated to quantify the impact of vascular disease on dementia are a much more realistic value than those calculated previously. So these PAFs were calculated in a single defined population that's been followed up for decades. And dementia in ERIC is prospectively evaluated and incorporates longitudinal measures of cognitive function to assess change over time. So this reduces some potentially strong bias that's attributable to education, attributable to socioeconomic status, and other psychosocial factors. Though we acknowledge that some of these measures we adjusted for are still proxies. Moreover, the inclusion of community-based surveillance for dementia allow detection of cases that would have otherwise been lost to follow-up. So this greater number of dementia cases further increases power and precision. And that this was a longitudinal study with individual level data also enabled us to estimate PAFs using this model-based approach that can account for the complex interactions between vascular risk factors that we found. So this was a major contributor to why the PAF was high even for midlife vascular risk factors relative to prior studies. And last, ERIC was designed with strong quality assurance and control measures, which can often be lost in these large studies that pull self-reported data from summary data sets to estimate PAFs of dementia. So kind of just getting back to the main thrust here. So overall, we investigated the summary contribution of vascular risk factors to dementia in a large community-based cohort study. What we found is that two of the most important vascular risk factors of hypertension and diabetes synergistically interacted in midlife to elevate dementia risk by 80 years. And in terms of how much dementia can be associated with vascular causes, we found that 22 to 44% of population-level dementia risk occurring by age 80 was attributable to 3 modifiable vascular risk factors measured in midlife through early late life. And so this signals that prevention efforts that target cardiovascular health could also confer substantial benefit to brain health. And a key message here is that the earlier it starts, the better. The effects of vascular disease are probably cumulative, so interventions targeting hypertension in later life, for example, among those who have probably had elevated blood pressure for decades, probably won't slash dementia risk to the same degree that midlife interventions would. And while we targeted 3 vascular factors that are more proximal to dementia, this further underscores the importance of other interventions for risk factors that contribute to hypertension and diabetes, such as physical inactivity and obesity. So again, the earlier the better. And overall, another key takeaway from these findings is that there's a significant prevention gap. Clinical and public health interventions in midlife, and possibly even through early late life, might substantially reduce dementia risk by 80 years. Dementia prevention strategies really that consider the health of individuals holistically and that target multiple risk factors will probably yield the most benefit in terms of brain health. And in terms of next step for this research, so one lingering question that's of interest is how hypertension in late life contributes to dementia risk. Results from observational studies are still fairly inconsistent, with some indicating null or even inverse associations with dementia risk. And again, as I alluded to earlier, it could be that there's unaccounted for heterogeneity in late life that's influencing these associations. So what we're currently investigating is whether these associations in late life are potentially modified by frailty. So I appreciate the opportunity to come kind of present some of these findings, and I'm happy to take any and all questions and comments. So thank you.
Maybe I'll just go first. Jason, thank you very much. Sean Savitz at UT as well. We really love your work. It's interesting. So, Rebecca Gottsman is on your list of authors. So when she and I were both, I guess, in the residency stage, we saw all this, pathologies on MRIs, and our radiologists would tell us, we don't know what this stuff is. It's unidentified bright objects. Chief of Neuroradiology called it rust, brain rust. And I guess, it turned out to be, what our worst fears, that it really is actually clinically significant. Because that was the big question back then, was it or wasn't it? And we were kind of ignoring it, I feel like, at that time. And so your work and others are really showing, indeed, this is like end organ injury. If the hypertension can cause problems like left ventricular hypertrophy or renal impairment, this is somewhat the brain equivalent in many ways. And so the data just seems to really go in that direction based on what you're showing. And now you're showing it at a population level. A lot of the people on this call are population scientists, School of Public Health. So it's really important message. Because I think a lot of what you're saying essentially is, this public health message has been out there to protect our hearts, and it's the same now about protecting our brains. So one question I have is, with all that data, is there any way to get an understanding of the class effects of high blood pressure medications, the antihypertensive medications that they're on? Do we have any sense at all whether that, if you've had high blood pressure for a certain period of time, we don't know that duration, how much that impacts later, but if you get it under control with certain meds, how much of that it contributes to the differential risk and, which medications. And I was just wondering if Eric has any of that kind of data that you could be exploring.
It's nice that you actually took this in this direction, because that's what I've also been thinking about. So right now in Eric, there's not necessarily good quality data on the specific medications. I wouldn't have faith in using different classes in ERIC to perform that kind of study. Um, but from my understanding too, so based on the literature, there's not necessarily uh, some of those systematic reviews did look at different classes, but from my understanding is that there's not necessarily any one class of medication that's better than the other. So what that means to me is that like, especially because this is presumed to be like end organ damage, any one of these hypertensive medications are probably going to be good for slashing risk, regardless of what you're taking. Because as long as you're like keeping blood pressure low, that's probably going to reduce a lot of the arterial sclerosis that builds up over time. That's just my understanding. So yeah, I appreciate that question.
And then another question I had is a couple of us, have been influenced by lectures on diet and the possibilities of lowering your blood pressure through dietary change, and how much of that is a mitigating factor. I mean, we think about Eric in the time frame that the data was collected, there wasn't as much emphasis on healthy lifestyles of diet maybe, or, physical fitness. And I was just wondering if you could comment on any of that, because some people have told me how just changing their diets recently to Mediterranean diet is substantially lowering their blood pressure.
Yeah, I agree with that. And a lot of the work that Priya is going to be doing in upcoming is focusing on not just like diet, but also life's essential aids in the ERIC study. So coupling not only a healthy diet, which is more distal to a lot of these other vascular risk factors, but also physical inactivity, because both of those contribute to a lot of these major vascular risk factors. Um, so I think that, you know, quantifying sort of how much risk could be attributed to those more distal factors would probably be helpful as well in future research too. So, but a lot of those measures as well in ERIC, I wouldn't, the data, the data might not necessarily be there for like diet quality, but the message, but I understand like the message here too. It's a good message to put forward.
Does make me think that the future of all this work is going to be going beyond Eric to new cohorts. As you're getting about as much as you can out of Eric and other data sets.
Yeah,
So,
going well beyond just Eric and going well beyond a lot of these risk factors, but also going even earlier in the life course too. So this is focusing on midlife and early late life. I think where we're going to be going is even earlier. What's the impact of diet quality, impact of physical inactivity earlier in the life course on influencing these vascular and cognitive outcomes? So I agree.
sorry, Blanca, go ahead.
Sure, no, very interesting. So, Jason, that's very nice. I know you mentioned towards the end that you're interested in looking at the relationship between frailty and cognition, and so that's a topic that I'm quite interested in. And so we know that frailty is a risk factor for cognitive decline and vice versa. In fact, there's
Mm.
cognitive frailty. But I'm just wondering if you're thinking of frailty, what in the relationship with hypertension, diabetes, or from what perspective? And I know you said that's the next stage, but I'm just
Yeah.
curious how you're planning to look at it.
Yeah, I also appreciate you raising this question too, because there's a lot of not only like methodological challenges, but the biology there is really going to have to be solid. So,
Mm.
um, for this upcoming work, we're mainly going to be focusing on hypertension. Um, Frailty is known to lower blood pressure, and a lot of these uncertain associations, and especially for like diabetes and smoking, although there's a little inconsistency in the evidence. I mean, diabetes and smoking are known to like they're most likely elevating your risk across the life course, especially like smoking. So it's really a lot of the uncertainty are surrounding hypertension, and because there's that close link between frailty and hypertension, that's why it might be interesting to look at potential risk stratification by frailty status. So where the hypothesis there would be that if there is effect modification, it would probably be most important for hypertension and not necessarily for diabetes or smoking.
So your hypothesis is that frailty will reduce hypertension?
So when we
So
look
it
at,
would be like protective for cognitive function, because that seems like you really don't want to get into a frailty status. So I'm not sure I follow, because what you're looking into prevention and protect the brain.
Mhm. So the primary hypothesis there would be in hypertension would be elevating risk in those that are robust and not elevating dementia risk in those that are pre-frail or frail, which is it'll be the biology there is there's not necessarily a lot of work that's been done in here. So that's why we're trying to explore why these associations for hypertension and dementia are kind of reverse of what we would expect.
Thank you.
Yeah. Mm.
I think there's another question from Trisha.
Hello, am I audible?
Yes.
Oh, yeah, thank you. It's my pleasure to be here today. I'm a final year medical student from Bangladesh, and I was just quite interested to know whether when we're designing some public health interventions, uh, has there been any study which compares like which one would be better to address whether the vascular risk factors and uh, with the memory training interventions as well? And like when you were just selecting the patients in your study, were there any considerations like their prior education level? Because as far as I know from the non-study, that dementia affected more for those patients who are having like lower degree of education and things like that with like no like they haven't didn't have that much memory training or something like that.
Mhm.
So I was just wondering if yeah.
No, thanks for asking that too. So the way that I conceptualize education in kind of this framework is that earlier life education and experiences are probably I'm going to try to choose my words carefully because this can mean a lot of different things across. So it might be providing a buffer against a lot of these lesions in later life. So getting at the concept of resilience. I am not necessarily an expert in resilience, but I think that accounting for how, you know, um, education and earlier life experiences can buffer against these negative impacts in later life is going to be important for some of these studies in the future as well. And incorporating some cognitive training, because that is still technically one of the priorities that was specified in the National Academy's report back in 2017, I believe. Looking at multi-domain interventions that not only target vascular risk factors, but also potentially cognitive training as well. And other risk factors such as hearing loss would probably be most effective. So it'll be interesting to see in I believe I believe in the US, there's another extension of a multi-domain intervention for risk reduction in later life. And I think that also incorporates not just vascular health, but lots of other risk factors that are targeting different mechanisms proposed that increase dementia risk. So the point here is that I would agree with you that targeting these multiple domains kind of holistically is going to be important. Thank you.
Yeah, great presentation. Actually, I like it. So one of the reasons also we're working also the similar presentation, like similar publication, but on a totally different cohort, which is Hispanic cohort. And we're seeing almost the same thing you're seeing, but really in a little bit of a reverse. So for example, diabetes is really shooting up all the cognitive impairment. Hypertension is not so much. You have ApoE allele is so limited or to nothing. So you alluded to this one. So yeah, I really agree with you. So the other thing also, I'm wondering if, so you mentioned PAF, right? So usually with PAF, you go for causal factors, meaning you have all the pathway from, exposure to disease, you have the pathophysiology. But my understanding so far, like for hypertension, diabetes, there's no clear pathophysiological pathways for these. So still, I think one of the next step in research should be going through these probably medical, questions, answering the pathophysiology of the hypertension, small vessel disease, for example, white matter hyperintensities. So I think that probably like one of these questions should come next to really establish some causality, because it's still, it's associated not to the level of causation, to my understanding, but probably I'm wrong.
No, I agree. So future research is going to have to better elucidate what these mechanisms are and how they interact with each other, and kind of starting to rule out some of these other potential plausible pathways. It is noteworthy, though. I remember seeing maybe last month there's a recent article in Nature Nature Medicine. That was a very big randomized trial that was conducted in China that actually finally showed a statistically significant reduction in dementia risk from aggressive hypertension treatment. And the effect size there was actually very similar to that was found in Sprint Mind. So there's still lots more to do, but a lot of these findings from clinical trials and from observational studies are now finally starting to kind of converge on especially the importance for hypertension.
So Jason, I also just want you to know your work definitely has an impact on those of us that, particularly community health workers, and how to educate. Many of the patient populations, the ones in South Texas or certain regions of the city, wherever you can go, right? I mean, urban environments that have very little access to healthy foods. It's also really important. I mean, so I can see how we would be using your studies to educate the public, that if you really want to make a difference and, you're in your 40s and you have high blood pressure, what I don't really know is how much you can convince people to change, their habits, if you tell them you're going to get demented 40 years down the road. It scares the hell out of me, but only because I guess we take care of these patients and see what happens to them. So, it's a larger philosophical thing, question. Overall,
Yeah.
that's why I love your data and I love following the papers that are coming out. I just wish there was more effective interventions or ways that we could convince the communities, of the importance of what this is saying.
Yeah, and I always like to close too with the caveat that this PAF research, what we're estimating is average population level dementia risk. And this is some of the pushback that I'm getting on the hearing PAF stuff as well. It's always important to communicate to patients that for these studies that are estimating PAFs, it's not applicable at the individual level to any one person, because again, hypertension and diabetes and smoking, there's no predictive value at the individual level for any of these conditions. But because there's a large number of people in the population at this small risk, it's contributing a lot more at the population level than like a smaller number of individuals that are at a higher risk. So it's always important to underscore that point. And it's also always important to contextualize all of these as well. So I live in Baltimore, so having to contextualize some of these if I'm contextualizing a PAF here that says hypertension and diabetes and smoking, it's associated with a high PAF. What that means is that for policymakers, it's not only important to put out public health, campaigns that target, healthy diet and healthy levels of exercise, but it's also important to get at more of those structural and political determinants of health as well. People don't necessarily have access to good grocery stores. They don't have access to green space. So what this really means is that we got to be calculating these at the intended level of intervention and apply what we're doing to the local realities. So I think that's a really important concept to highlight.
Yeah, we're all with you.
Yeah.
So what's coming next from you? What will be what will be your next jam of paper?
Hopefully frailty.
Well, that is very important. I mean, there's no question.
Risk stratification in later life should provide a really good message for understanding etiology in later life. And I think there's also a really important clinical message that's embedded in that research as well. And also a lot of this future work too, trying to figure out to what degree these vascular risk factors are impacting, especially plasma biomarkers and other biomarkers for not only AD, but also biomarkers for potential vascular contributions as well, which will help bolster the kind of the message that we're finding in these large PAFs. So that's a lot of where we're taking this in the future. And again, kind of like why I emphasized these PAFs need to be kind of contextualized really well, looking at PAFs like you guys brought up too, across contexts and different populations. So especially in like this Hispanic cohort study, these vascular risk factors, like the profiles differ very much across populations. So the message is a lot different. So we need to calculate these at whatever intended level of intervention that we're gunning for. So that's also going to be a lot of really important future work.
Great. I mean, it's great to hear. I mean, there's a lot of synergy. Colleagues who are taking care of the patients, been clearly seeing, these ApoE4 negative, patients, and seeing much more of the contribution of vascular risk factors. So, and I love what you said about the fact, like, it's just interesting, you're in your 70s or 80s, you're like, well, you got high blood pressure, may not be able to do too much for yourself at this point with your brain, but at least obviously there's still the message of cardiac because, that's still the number one cause.
Yeah.
But that the other pathologies are all at play at that point. Just like you said, and now we're seeing that dementia is really multi-etiology, in those patients at that point.
Yes.
So fascinating.
Mm.
Okay. Okay, Fadi. Sounds really great journal club.
Yeah, thanks, Jason, again for a great presentation. I think we will conclude this, even we passed that 5 minutes after time. So thank you. Yeah, thanks everyone for joining, and see you next month. Thanks.
Thank you, Jason.
Again,
thanks so much.
Yeah, appreciate the invitation, and always happy to collaborate. So
we'll look forward.
Yeah, let's figure that out. Yeah, Fadi, you should stay connected with them.
Yeah, exactly. Yeah, I mean, we're in the similar. We're doing exactly the same thing, probably different cohorts. So yeah.
It's all contributing.
Perfect.
To,
Yes, sure. We'll be in touch. Thanks, Jason. Thank you, everybody.
Thanks again.
Thank you, Jason. Thank you.
Take care.
Thank you.